University of Athens, for those who are international attendees from the website connection. Professor Tsioufis is the chair of the session, and I'm pleased to start up by offering the top 10 advances of transcatheter valve therapy 23-24 in this topic hereby. And this, first of all, let's talk about the major event that happened a few months ago, because one of the fathers of TAVR, as you see here, Professor Andersen from Denmark, the pioneer of the animal laboratory experiments that established the feasibility of percutaneous valve technologies in the pig model, received the Society of Cardiac Angiography and Interventions Award 2024 this May in Long Beach, California. But just a month or so before that, the father of the clinical TAVR, Monsieur le Professeur Alain Cribier, died suddenly in April 2024. And as you recall, this is 22 years since the first human TAVI. Here is Professor Alain Cribier with the initial patient. So after this, I think, very remarkable a reminder of events of the pioneer of TAVI, let's talk about the top 10 advances in rather fast speed in order to make the time. The number 10, going from 10 to up, is the left atrial appendage for AFib during TAVR, the Watch TAVR study, which is a small study but innovative, randomized patients with TAVR plus appendage occlusion versus TAVR plus anticoagulation in patients with atrial fibrillation undergoing TAVR. The results, not as anticipated, no much difference in the two groups as far as the stroke or major bleeding, and neither in the mortality. It seemed to be maybe some benefit by 12 months, by 1 year, maybe by 2 years, things kind of settle down very similar. And as you can see, also very similar when you consider the stroke and the major bleeding. Perhaps a much larger study might be able to detect if the 1% of stroke rate or the bleeding might be of any difference, but just a couple of percentages up and down, not a lot of mileage in this approach. Let's go to number 9. TAVR now coming up in pure aortic regurgitation, and we have this innovative valve, the Jena valve trilogy. You can see it seems like very close to the self-expanding designs of the Evolut and Navitor, but just as like a very short one and kind of anchors around the 3 leaflets of the native aortic valve. And we had a feasibility study presented for the first time at TCT 2023, 30-day and 1-year endpoint, 95% success. That's very important because one of the problems with this valve potentially, or any valve, for aortic regurgitation is that because there's no calcium, the valve may fly out. So the 95% completion rate, that was a very, very high success rate, very, very important. And this is the statistics, if you want. There were some computation indicating that they anticipated the 25% non-inferiority margin as far as mortality, and they were at 7.8 to 12%. So in general, they performed better than expected. Most important, though, the real results here is a regurgitation that was reduced incredibly. So we have feasibility results of this approach, and we're waiting for the next one, for the next study in much larger, I'm sure. Number 8, timing of TAVR, PCI timing in TAVR. Many trials around that, many studies. In these last years, we had the Revasc TAVI. Complete vascularization was incomplete revascularization. And you can see here, if anything, if you stage it after the TAVI, there seems to be some advantage. Perhaps it's a selection. This is not a randomized study, but indicates that the need for a randomized study. And I think that's what we're kind of gearing up for, the complete TAVI trial that's going to come up next year. Other item, stroke after TAVI, with or without embolic protection. We heard about the randomized trial last year. This year, we heard about the TVT registry results in the United States, with or without embolic protection. You can see the thousands of patients here because it's all TAVRs in the United States as written down in a registry. 53,000 with embolic protection, 360,000 without embolic protection. The results very, very encouraging. Why? Forget about there's no difference. The important thing is that in-hospital disabling stroke in so many thousands of patients, under 1%. This is a terrific result, tremendous result. And even if you consider the minor strokes, clinically important minor strokes, you are at 1.3 to 1.4%. So not much window really for embolic protection to show a difference, but very, very important, very, very tremendous, I would say, safety profile with very low stroke rate as practiced in the real world in the United States. Number 6, a lot of discussions about TAVI and SAV, surgical and transcatheter valve degeneration. Valve in valve, TAV in TAV, all various combinations, and the first results about TAVR explants. A very difficult operation, it seems to. The surgeons have to put their arms around that. What do I mean by that? First of all, redo TAVR registry presented by the Cedars-Sinai group. And again, in the TVT registry, 365,000 patients they started with. They compared about 1,300 redo TAVR versus 1,300 native TAVR of some propensity matching. It's not a randomized study, obviously. The main message is not much difference in this around the United States, centers of excellence. Not much difference when you do a TAVI in TAVI versus an original TAVI. Not much difference. I say, okay, why is that important? You can tell me. Well, it's very important because when we know subsequently, you can see what's happening in surgery after TAVI. You're going to see that these results are actually very important, although right now they seem a little boring. So, redo surgical aortic valve after prior transcatheter valve. And this is the study design led by the University of Oxford. And ultimately, at the bottom right, you can see isolated AVR, 12,000. And after some propensity matching, they had some surgical AVR treated with TAVI, 400 patients, and another 400 patients of surgical AVR treated by repeat surgical AVR. And you can see here that the results weren't so good when you do SAVR, TAVR after SAVR, and SAVR after TAVR after SAVR. They seem to also be somewhat different. You have to be a little careful in the real world when you're trying to do all these complex operations, and perhaps surgical groups have to be very careful about developing better techniques in handling patients with prior TAVR. Another aspect of the explant TAVR international registry, I advise you to just look at the very bottom landmark analysis, redo versus explant TAVR. The explant TAVR, a lot of events at 1 month. So a lot of acute surgical mortality, 11% versus 3%. And beyond 1 month, not much difference between the groups. So that's why I'm saying there's a lot of situations in the surgical procedure after TAVI. Attention needs to be needs to be paid by the surgical groups into perfecting their techniques. There are a lot of patients who got in TAVR that made the surgery afterwards. Let's move on to another type of intervention, mitral valve, edge-to-edge repair. A lot of data, particularly durability and longer term. As you remember, the COAP trial, now we have 5-year data of the COAP trial with very, very encouraging results. The mortality difference persists, 10% difference, 57% versus 67%. Let me actually also pay attention not only to be happy about the difference of 10%, but also recognize that by 5 years, 60% of those patients will not survive. All right? So it's one thing to say, okay, we're doing better. Well, but you know, these patients are really, really sick. So the prognosis of these patients is maybe very happy the first month after the procedure because the procedure went well. But we have to be careful that we keep the patients and the families with very close clinical cardiology and heart failure follow-up because the mortality is staggering despite successful procedures. I also would like to pay attention to the secondary analysis that includes not only the groups of mitral clip versus medical therapy, but also includes patients who were on medical therapy initially, but got mitral clip subsequently, this orange group, that you can see that they mimic the mitral clip group, which means that is a secondary proof that the mitral clip indeed helps out this population, because it's not the group assignment, but if that group, for whatever reason, they were crossed over and received the mitral clip, they behaved exactly as a mitral clip group. Very important results now all the way to 3 years. Important results coming also from TVT registry from another group that was functional MR I spoke to you about. Now talk degenerative MR in the TVT registry. Degenerative MR, it's also another situation that we may not achieve a good seal by the mitral clip. And that is no news. It is what it is. Very important to see that the mortality at 1 year, it's again very important. It's not small. 12% with mild MR residual, 27% where you continue to have severe MR, and about 18% who have moderate MR. Again, to understand that the reduction of MR in the patients with degenerative disease closely linked with mortality, and again to point out that even if you have good results, the mortality remains a lot. 10 to 20% mortality at 1 year. So again, all these patients, it's good to be very happy at the 1 month follow-up, and you really have to be on top of them as far as heart failure and other managements because the mortality is there. Also a second device, the Pascal, also another method to clip with a different device, coming up also with very good results, and we look forward to further clinical results from this device. We have 6 months, very good imaging as well as New York Heart Association CHF class improvement. So let's move to another aspect, TMVR now, mitral valve replacement. And I know we're going to have this very valve, Intrepid, out in the simulation outside. Anybody wants to try that? We have 1 year results of this study and the 5-year results of the mitral trial that indicated that the best results exist with mitral valve in valve versus a mitral valve in ring or in calcific valve, that again seem to have a lot of mortality, about 36%. Excuse me, about 75% mortality, 67% mortality if they have ring or calcific valve. Again, these patients, we may be very successful into implanting a valve. Their survival rates are not that encouraging because of the nature of the disease they have, and we have to be very careful not to overrate our technical success. On the other hand, if patients has valve in valve, the results seem to be much better, with a mortality of only 20% at 5 years. Let's go to number 3. A big new technology had a lot of devices approved, even in the United States, which is usually the last level of approval. This is a tricuspid valve. Have that triluminar results with a tri-clip and even a percutaneous valve approved there. You can see we have coaptation devices, suture annuloplasty, ring annuloplasty, a new valve implantation, and the transcatheter tricuspid valve replacement. All these are possible. 3 of them have approvals already. And the big study Coming out of here, Transcatheter, out of this paper, Minneapolis Heart, Transcatheter repair for patients with tricuspid regurgitation, and you can see there was a staggering improvement in the hemodynamic parameter. Why do we focus on that? In my view, because nobody really understands the tricuspid-related clinical syndromes yet. There's been an understudied valve. Typically in surgery, this is associated with other valve replacements or repairs, so it's very difficult to understand exactly what patients benefit or even suffer from isolated tricuspid valve. Very difficult to know that. But now we have a device that's specific with tricuspid valve. We want to start understanding that better. A lot more research to be done in this population. This is the TDVR, safe and effective in a real-world population. Again, small data results, but a lot of staggering decrease in the regurgitation rates and very low cardiovascular mortality. Also, there is another clip system for the tricuspid valve, again with great hemodynamic results. Again, all these devices approved for tricuspid valve, but clinical data yet to come in a large scale. And this is the tricuspid bioprosthetic valve. Actually prosthetic valve, but which is both bioprosthetic and a lot of metal though. There is obligatory lifelong anticoagulation in this study, which is one of the major criteria to do or not do the valve. You can definitely not consider the valve if the patient has given a relative contraindication for anticoagulation, because there's a lot of chances of thrombosis if you don't give anticoagulation. So you've got to be very, very careful, particularly because tricuspid regurgitation is associated with hepatopathy and bleeding diathesis. So it's very tricky. And a new member of the heart team has joined, which is the hepatologist. A lot of severe tricuspid regurgitation patients need to be seen by the hepatologist. Sometimes even liver biopsy is required in order to understand is the partial hepatic congestion related hepatopathy / early cirrhosis, or a non-reversible, perhaps alcoholic or other cirrhosis playing a role. And in that case, of course, a therapeutic plan could be rather futile. If you really going to replace a valve and you remain with severe cirrhotic alcoholic hepatopathy, you don't really achieve much from a clinical point of view. So number 2, TAVR versus SAVR. In the various trials, I'm going to focus in the Notion 2, it was presented in the Transcatheter valves just a month ago, a few weeks ago actually. A randomized comparison of TAVR versus SAVR in a younger population, just under 400 patients, 80 patients per group. Interestingly, and the most interesting is that this, although small, included a tricuspid and a bicuspid cohort. Overall, not much difference in death, stroke, or rehospitalization. And death or disabling stroke, not much. But very important to note that there was a lot of difference. When you talk about tricuspid valves, tricuspid aortic valves, tri-leaflet, I should say, aortic valves, no difference. When you talk about bicuspid aortic valves, there seems to be that TAVR not so good in this population. So we wait for bigger trials about this. Interestingly, TAVI versus SAVR in a low-risk patients coming also from another group in Germany. This time a very bigger group, 1,400 patients, 700 per group. And this was mostly a tri-leaflet valve with much favorable results with the TAVI group from the German operators versus the German surgeons, 5% versus 10% one-year mortality. Clearly, much seems to be that in Germany, the TAVI was better than surgery the first year. Finally, the Notion group also had a Notion 1 study, and this year they showed that the 10-year mortality was identical between TAVI and SAVI. Why am I showing that? Because there's a lot of situations and concerns about the longer-term durability. But in my mind, always the leaflets were manufactured by the same process, I never really thought that there would be any difference, and apparently there isn't any in the longer term. And it's all derived by the gradient and by the evolution of the gradient over time. And staying there, the #1 study of this year, presented just a couple of months ago, and we're going to hear about it in greater extent. Just to give a snapshot, small aortic valve annulus in TAVR, the SMART trial, with about 760 patients treated here with Evolut versus Sapien. Mostly Evolut 26. Why? Because a supraannular valve, you can implant a bigger size versus the smaller 20 and mostly 23 size Edwards valve. That things overall, from clinical point of view, not much difference, but when you look into the gradients, there seems to be a staggering difference of only 9% versus 40% chances to meet the gradient-derived definition of bioprosthetic valve dysfunction, which includes a gradient of mean gradient over 20. So that's very, very important. Clinical thrombosis, of course, endocarditis and valve intervention is very, very low, and we're going to look forward to future results of this study in figuring out. So these and others have been part of the ACCHA as well as the ASC HCTS guidelines. I think I advise you to go there. And of course, I want to also remind you to join us next year in Washington, D.C. at the Photicity in October, or for the SCAI in May 1, the Society of Cardiovascular Angiography and Interventions in Washington, D.C. to discuss this and others next year, before, of course, we meet again here next June. Thanks so much for your attention.
Thank you so much, George, for this excellent overview of the advance in this important topic of transcatheter valve therapy. It is good for the patient, for our patients, to see that all these trials that you presented addressed important issues in the management of patients. It is good to see that TAVI is a good solution, at least as good as the TAVI for native valve. It's good that now also for the small aortic annulus we have a good solution. So I think the future will be fantastic according to what you present. I don't know if there is a time, if you have time for questions, or we can proceed to the next lecture.
Dr. Iacovu, one question.
Okay, just a small one. So, it's amazing how things evolved, and Arik, I don't know if you agree, you have been from the start there. So there are so many interventional capabilities of fixing these valves, to fixing all these old solutions that you cannot do anything before. But I would like to stick to 2 points. The first is explantation data. So if you have a 17% mortality rate, maybe TAV in TAV maybe is something that we need to consider, maybe to choose a proper, maybe annular valve, as a first valve. And the second, given that especially in the States, the TVT registry shows that 95% of aortic stenosis are treated with TAVI after 65. So maybe, and in regards of bicuspid data and the notion 2 that you just showed, George, so maybe we need to maybe don't go that fast in these younger ages. Do you agree with that?
Yeah, I think what is very important to understand that both TAVI and surgeons related with our surgeon partners also have some things to learn. Looks like TAVI will have to learn more about the bicuspid in younger people, and our surgeon partners need to learn more about TAVR explantation, something in their mind they try to avoid. But nonetheless, it doesn't matter what we try to avoid. What matters is what's happening in the real world, and the patients do have many TAVIs, and many of them some of them are going to need reoperation or reimplantation of some sort. So everybody's got to get a little bit up to speed with those techniques. Patient-centered approach. Yes. Well, one more question. There's microphone by your seat, but if not, just say your question and then I will repeat it.
Yes, a wonderful question. My name is Yanni Augustidis. I'm a cardiac anesthesiologist from Penn, Philadelphia. I just wanted to ask you, why do you think there's such a mortality rate despite the successful mitral clip? Because the 5-year data is very disappointing. So do you think that's heart failure driven? Is that an opportunity for VADs and mechanical assistance? Because it seems like drugs are not doing the job.
Yes, as you know, I mean, those data are for functional MR. This means patients who primarily have heart failure. And really we're dealing about heart failure mortality, which clearly is only in part associated by the improvement in mitral valve because the myocardial process continues. And yes, indeed, we also use mitral valve as a bridge to LVAD or bridge to transplant. And in my view, there is a new generation of a new subspecialty. I call it at least, the heart valve-related heart failure, which is a new thing. Most heart failure specialists in any hospital, traditionally, when they went to train, there was only transplant or LVAD. So that's what they're really used to. The last 5 years or so, they need to have to understand what they're doing or what they want to do, can they do in valve-related heart failure, even with isolated valve intervention, something they're not used to. They were used to wait for medications, consider transplant, or consider multi-valve surgery, but they never had the chance to really study and get familiar with what can happen if you have a step-by-step. Fix the mitral, maybe fix tricuspid later, maybe not, how to adjust, how to select patients. So it's a learning curve, I think, in the heart failure community. We have a lot to learn and a lot more to do there. Terrific. Costa, we can proceed to the next session.